Hello everyone, good morning. I'm Professor Adelfa Dusaran, your medical surgical teacher for today. Today we will going to discuss our concept related to oxygenations, and the subtopic of it is about endotracheal tube management and suctioning and also ventilation. Now I have some objectives for today's lecture. Number one, at the end of the lecture, the students will be able to identify the use of the ventilator, be oriented on the settings of the ventilator, enumerate the nursing care of patients on ventilator, what is the purpose of intubation and its equipment used, how to do your suctioning on the intubated patient, and also I have some video to let you watch related to the ventilation. So first, what is a mechanical ventilator? So a mechanical ventilator is a machine that helps the patients breathe when they are having surgery or cannot breathe on their own due to a critical illness. Now, there are different kinds of your ventilator. So 1, 2, and 3 or 4. These are the different kinds of your ventilator. Now in the ICU, we are requesting the Josnil company to request for the ventilator, but of course we have also our own equipment, facilities in Iloilo Mission Hospital. So what is the goals of your mechanical ventilation? So the first is to relieve respiratory distress. Now there are patients, critical patients of course in ICU that suffers from respiratory failure, and of course they will be having symptoms of respiratory distress. Then decrease work of breathing. If they are having no energy to breathe on their own, so they need to be ventilated, and in order to have a normal respiratory pattern. Another one is your improved pulmonary gas exchange. So this one, by the result of your arterial blood gas, you can identify if the patient is having gas exchange, like for example, metabolic acidosis, alkalosis, or respiratory acidosis or alkalosis. Another one is respiratory muscle fatigue. All right, so those patients having suffering from myasthenia gravis or GPS like that. So the respiratory system is affected because of neurological problems like that. Then we have permit lung healing, like patients who is suffering from pneumonia or COPDs like that. So ventilation is necessary to keep them be safe on the respiratory problems. Then the last is to avoid complications. Now, there are ventilator modes that we should consider. The first one is the controlled mechanical ventilation. So for the controlled mechanical ventilations, we have the what you call your patients is having this mode of ventilations in which the respirator delivers the preset volume or pressure regardless of the patient's own inspiratory efforts. Now, for the assist control, initially we are having these modes, because it is indicated in patients without deep sedation who are able to initiate respiration. but who cannot maintain spontaneous respirations. And of course, this kind of mode is a very friendly modes of the ventilator settings. Another one is your intermittent mandatory ventilator. When you say intermittent mandatory ventilator, it is refers to any mode of mechanical ventilation where a regular series of breaths are scheduled, but the ventilator senses patient's effort and reschedules mandatory breaths based on the calculated need of the patient. Now, we have also ventilator settings. Now, in the ICU, we are responsible for the ventilator settings that the patients will be having. So we have to check the doctor's order. You can ask the respiratory therapist to go to the ICU and assist for the ventilator settings. Now, the number one is, of course, your mode. So, as I have said, the modes of the ventilator are assist control, controlled is IMB mode. Then the other one is your fraction inspired oxygen concentrations or your FiO2. When you are talking about FiO2, it is an estimation of the oxygen content a person inhales and is thus involved in gas exchange. At the alveolar level, inhaled atmospheric gas, and that is 21% oxygen. Now, after the patient's been intubated, the highest FiO2 that the patients can have is 100% and the lowest is 30%. But after 1 hour of being on the 100% FiO2, the patients will be having an ABG, your arterial blood gas. Now, the doctor will determine the FiO2 uh, related to the patient's according to the ABG result of the patient. Then, that's the time that the FiO2 will be lowered to it's either 80%, 90%, 70%. But as I said, the lowest FiO2 can be given to the patients as low as 30% or 21%. Now, for the tidal volume, the TV, your tidal volume uh, is the lung volume representing the normal volume of air displaced between normal inhalation and exhalation when extra effort is not applied. So, is the amount of air that moves in or out of the lungs with its respiratory cycle. So it measures around 500 ml with its respiratory cycle. So this is an average. Your 500 ml is an average tidal volume for a healthy adult male. And for the female, you can have approximately 400 ml in the healthy female, your tidal volume. Another one is your backup rate. So your backup rate means to say the patient's, like for example, if the backup rate of the patient is 16 and you set the ventilator at 18, so this set back up rate about 4 beats per minute below the patient's spontaneous rate. So, like for example, 18 is your patient's backup rate, but you set the ventilator into 16, okay? Then you go to the PEEP. When you are talking about PEEP, that is your positive end expiratory pressure. So your PEEP is, uh, this is when to increase the volume of gas remaining in the lungs at the end of expirations in order to decrease the shunting of blood through the lungs and improve gas exchange. But please remember that the parameters of your PEEP should be considered. Like for example, the blood pressure of the patient should be within normal limits. Now, if the blood pressure of the patient is below 90, the patients will be evaluated, no, for further changing of the setting of your ventilator. Then, the peak flow rate. When you say peak flow rate, it is the maximum flow at which a set tidal volume breath is delivered by the ventilator. Now, it should be titrated to onset the patient's inspiratory demands. Now, the peak flow rate indicates that the patient is already, uh, if you're going to titrate this one, the patients will be already on the weaning process. So you can titrate that one from higher to lower according to the patient's inspiratory demands. All right. Then, when we are talking about the ventilator, there are nursing interventions that you are supposed to give to your patients. So, as a student nurse, we are uh, having the responsibility. We are having the responsibility to take care of the patients, no, from airway, breathing, and circulations. Remember, oxygenation is very important, and the use of the ventilator is not just an ordinary. So you have to be responsible. You have to take care of the patients in order to maintain a patent airway. Now, how are you going to maintain the patent airway of the patients when she is on the ventilator? Of course, by number one, by suctioning the patients regularly but with limitations. You first suction the patients orally, at least 10 seconds, and then change the suction catheter and suction the patients into in the endotracheal tube for a maximum of 10 to 15 seconds. As I said, there is limitations for suctioning of the patients. Another one is you have to assess the O2 saturation of the patients. How? The patients will be attached to the pulse oximeter. So the right axis for the pulse oximeter is on the right index finger of the patients. But there are 3 or 4 sides of your pulse oximeter. It's either on the fingers of the patients, on the earlobes of the patients, or on the feet of the patients. But the most accurate access for the pulse oximeter is in the right middle finger of the patient. Now, the O2 saturation ranges from 95 to 100%. The more you suction the patients, the more you are getting the oxygen from him. So you have to assess if the patient is already cyanotic or the patient is already having a rapid respiratory rate and the O2 saturation is already 95 and below, you have to hyperventilate the patients. When you say hyperventilations, you have to do uh, suctioning in limitations, and then you have to ambibag the patients to hyperventilate the patients. Or you can set your FiO2 to much increase oxygenations. Like for example, if the FiO2 is only 60%, you can hyperventilate the patients to 100% while suctioning. Now, again, you have to assess properly during suctioning if the patient is responding to you properly or you are making the patients uncomfortable during suctioning. So make your patients comfortable as much as possible, no? And observe the O2 saturation of the patients. Then, bilateral breath sounds for adequate air movement. So, before you do as a part of your nursing interventions, it is very important to auscultate the lungs of the patients and properly observe for bilateral breath sounds, meaning to say your tube is intact, you are on the right track, no, while giving nursing care to the patients. Then vital signs monitoring. So it is very important to monitor the vital signs every hour, Q hourly, like that. Okay, no, from neurovital signs to vital signs, and also you have to observe the changes or unusualities in the vital signs of the patients. Then, assess patient's pain. Remember, the presence of the tube is very uncomfortable to the patients. Try to assess the pain scale of the patients by communicating to the patients regularly. Although they cannot talk, they can have some communications to what gestures like that. So you have to ask the patients, what is your pain level at this time? Is it 8 out of 10, 5 out of 10, or 10 out of 10? Now, for pain, you can assess the patients properly. Like for example, the patient's BP will be high, no, because of pain. The respirations will be high, and the patients will be tachycardic. And of course, the facial grimace, facial expression of the patient is changing because of the pain. So in that case, you have to give analgesic or any pain reliever to the patients according to the doctor's order. Then anxiety. Anxiety and sedation needs and medicate as ordered. So there are medications that are slight having effect. No? Like for example, diazepam or like that in order to lessen the anxiety of the patients. Of course, you have to talk to the patients. You have to give comfort, reassure the patients to lessen his or her anxiety, right? And then, of course, other nursing interventions is that you have to ensure that your endotracheal tube is well secured. By what? By trying to keep in touch with a plaster like that, the tube of the patients will be properly aligned. It's not kink, okay? And then you have to do regular checkup of the endotracheal tube. And the positioning is very important. Then, of course, you have to identify the patients appropriate for extubations later on, okay? So again, these are some nursing interventions of the patients. Then of course for safety and security of the patients. So please try to orient the patient's contraptions. Try to introduce the patients, sir, this is your tube, this is not to be taken out, and this is very important. This will help you to maintain your respiratory pattern like that. Then of course you have to um, maintain aseptic technique. Now, during suctioning, during giving of feedings to the patients, you have to make sure that you maintain aseptic technique by washing your hands before touching the patients during the procedure, or even you are going to wear gloves, no, when you are taking care of these patients. Then, of course, turning the patients every 2 hours is very important. So be sure when you turn the patients every 2 hours, you have to take note of some of the bony prominences that, bed sores will possibly occur on that bony prominences. Then, yes, communication is very important. So even comatose patients can hear you. So the last senses of your patients in that state is the sense of hearing. So try to communicate with your patients while on the ventilator. Try to talk to them to lessen anxiety, and then of course reassure the patients that this tube will not take long. This will help you, and hopefully soon it will be taken off from them. All right. So there are so many things that you can do, no, in order to make your patients comfortable. All right. Next is the what is the mechanism of the ventilator? If we know the mechanism of the ventilator, you can also share that to the patients. So a ventilator blows air into the airway through a breathing tube. One end of the tube is inserted into a patient's windpipe, and the other end is attached to the ventilator. The breathing tube serves as an airway by letting air and oxygen from the ventilator flows into the lungs. Okay? Then I'm going to introduce to you the ET management. What is ET management? So this is your endotracheal tube management. Now, there are so many purpose of your intubations, no? The number one is that the opening up the airway to give oxygen. So intubation is the process of inserting a tube through the mouth and then into the airway. So it is done so that the patients can be placed on a ventilator to assist with breathing during anesthesia, sedation, or severe illness. Okay? Other purpose of your ET management is to remove blockages, like for example mucus secretions like that. And then of course this one helps the patients breathe, no, when they have collapse of the lungs or they have heart failure or trauma. Okay, so this is how the patient is intubated. So this one is the tube that is inserted to the patient. Okay, so this is your laryngoscope. Remember, your laryngoscope will be functional. There is a light over there. And this is the doctor. The position of the patient is flat on bed. You have to hyperextend the head or the neck of the patients. And you can see the trachea and the esophagus. Alright, so the doctor is trying to insert now the ET tube like this. Okay, so as a nurse, you have to assist the patients during intubations like that. Okay, then other one, we have some equipment that you are supposed to prepare during intubations. So first is the laryngoscope. So there is a light, the with light conventional, and then the flexible fiber optic bronchoscope, and then the ET size. Normally, we are using size 7 for intubation, but the different sizes of your ET is from 6 to 9. The lowest is 6 and the smallest is 6 and the biggest size is the size 9. Then you have to prepare Vaseline gel to lubricate your ET tube. Then your gloves, sterile gloves or, then syringe. The syringe is size, the 10 cc syringe because you are going to inflate the balloon of the ET tube if it is intact already by using your 10 cc air syringe. Then the transport tape in order to secure the tube on the patient's mouth or face. Then your stethoscope. Your stethoscope is used to auscultate the sounds, no, if your tube is in place. And then, of course, the mouth guard. Mouth guard is you're going to place that in order to do oral suctioning very good to not to bite that tube of the patient. So mouth guard can help to extract more fluids or saliva discharges from the mouth of the patients. Then, of course, your suction machine. So, suction machine should be at the bedside of the patients, and then suction tubing. So, the suction tubings will be it's either for oral suctioning and for ET suctioning. So, what are the nursing care that you're supposed to do with the patients on it in the tracheal tube. So ensure that the required oxygen support is indicated is provided. So, for example, the O2 saturation will be what, how many percent, no? So again, from higher to lower O2 saturation, or if fraction inspired of oxygen. Then you have to assess the respiratory rate status at least every 2 hours or frequently as indicated. Take note of the changes in the respiratory status of the patients and do a very good assessment and refer at once. Then ensure that adequate humidity is provided to avoid feeling of dryness in the oropharynx. So this one you can provide um, mouth care through the patients. Okay. Then there are some clinical signs and symptoms of correct ET placement. I'm sorry. First, you have to assess for the breath sounds, if it is heard clearly in both lungs. And then the chest movement, patient's chest rise and fall with each breath. And then prompt increase in heart rate. And then confirmation of positions of direct bidirect laryngoscopy. This one also can be done through X-ray. You can request X-ray by portable and then try to assess if the ET is in the right place. Then, of course, observations of your endotracheal tube passage through the vocal cords. Remember, if your ET tube is not in place, you can hear the voice of the patients. Okay? But if your ET tube is in place, of course, you cannot hear any sound from the patients. Then, absence of breath sounds in the epigastrium condensation. So remember, uh, your ET should be on the lungs, not in the epigastrium of the patients. Okay? These are the clinical signs and symptoms of correct endotracheal tube placement. Now, when you do your patient's assessment, there are signs and symptoms of patients with an oxygenation problem as well. So this is very important because you are documenting this in your nurse's notes. You are referring this to the doctors. Any changes in the patient's color of the skin, like cyanotic or ranging from blue to cherry red. So you have to document that one. You have to assess that one properly. So starting from the lips, if you can see bluish discoloration, and also the skin or the fingernails of the patient. So that is one sign of your oxygenation problem. Another one is confusion. All right. Now in ICU, we used to monitor the patient's neurovital signs every hour. So you can really recognize if the patient is having this kind of problem. Then cough. So cough is either productive or non-productive cough. No? Mean to say your problem is getting worse, no, for this. Then increase fast heart rate. So the cardiac rate is ranging from 60 to 100. Now above 100, like 110, 120, 130, 140 is very detrimental to the patient's conditions. Then rapid breathing. So the normal breathing is only 18 to 20, like that. 24 is just okay, but 30 and above is already a very bad signs. Then shortness of breath, if the patient is gasping for breath, so you have to assess it properly. Slow heart rate, no? The patient is having a heart rate of 80 and below, like 60, 70, or like that. Then the last is sweating. Sweating profusely. Now you can see the patients having problems really. No? So you have to be alert. You have to be skillful in the signs and symptoms of oxygenations to your patients. Okay. Now, these are some ABG normal values that you can consider for the patients with ventilator. Now, this is very important because you are going to assess the patients if there is some deviations of your ABG values. Like for example, if the pH of the patients, the normal pH is 7.38 to 7.42. Now, when you are going to interpret your ABT, you look for the pH. Now, if the pH is below 7.40, meaning the patient is acidotic. And if it is 7.40 and above, the patient is alkalosis. Now, if the pH indicates acidosis, what will you do? Then look at the PaCO2 and bicarb of the patient. So you can see the PaCO2 is 38 to 42 mm mercury and the bicarb is 22 to 26 MEq per liter. Okay? Now, if the PaCO2 is increased, then it is primarily respiratory acidosis. And if PaCO2 decreased and bicarbonate is also decreased, this is primarily a metabolic acidosis. Alright? So that is a simple interpretations of your ABT. Okay? Now, as a nurse, you have to be to be alert also, no? So in case you will have a face-to-face clinical duty later on, please do remember the ABG normal values, especially if the patient is having oxygenation problems. And also remember in ICU, you have to be alert as well. You have to be knowledgeable in these kinds of normal values when it is related to oxygenation of the patients. Right? So these are some common complications of suctioning. Now, when you do your suctioning, it's not only by getting the drainage or the sputum of the patients, but you have to consider all these things as well. So first, the hypoxia. What is the meaning of hypoxia? When you say hypoxia, it is a condition in which the body of the region of the body is deprived of adequate oxygen supply at the tissue level. Then, airway trauma, the soft tissue swelling and edema will be noticed also. Psychological trauma, all right? Now, patients during suctioning should be properly oriented. Sir, I'm going to do suctioning on you. This is quite painful, but you have to be patient because it is the procedures that will help you improve your conditions like that. Okay, so try to reassure your patients, try to reduce the level of anxiety of the patients during these procedures. Then pain. Of course, it is very uncomfortable for the patients. No? Just try to evaluate the pain scale of the patients while you are having this suctioning. All right? Then bradycardia. Try to know the cardiac monitor if the patient is already having low cardiac rate, no? Like 80 and below is not already good. Okay, so try to reassess the patients properly. Then, of course, infection. That's why you have to maintain strict aseptic technique during these procedures. Wear gloves, wear your mask, and of course, try to make sure that the right suction catheter will be in the right path, on the right way, like that. So, proper disposal of your tubes should be very, very important. Okay, and then ineffective suctioning. Now, when you do your suctioning, be sure that you are able to get all the secretions from down on the tip of the suction catheter of your endotracheal tube. So ineffective suctioning is um, um, a process wherein, of course, the patients will suffer if you are not good, no, in suctioning the patients. So you have to consider the it is size of the patients and then the size of your suction catheter as well, right? Okay. So this is how you are going to do your suctioning. So this is your suction catheter. All right. This is the the beginning, the opening of the suction catheter. So you are going to insert the suction tip on the ET tube of the patient. So until here. Now, if you're going to suction, try to be sure that it is properly in depth of the endotracheal tube, so that you can remove the mucus secretions properly. Okay, so remember, this is the trachea, this is your mucus, no? This is your tracheostomy tube, and this is the suction catheter going inside in order to clear the tracheal tube, right? So that is my explanations about your mechanical ventilations and for the problems of oxygenations and other nursing interventions for patients having oxygenation problem. Now, for some enhancement, I want you to watch the video. I want you to be oriented and to be also knowledgeable about mechanical ventilation. Okay, please watch this.
In the 16th century, Flemish physician Andreas Vesalius described how a suffocating animal could be kept alive by inserting a tube into its trachea and blowing air to inflate its lungs. In 1555, this procedure didn't warrant much acclaim, but today, Vesalius's treatise is recognized as the first description of mechanical ventilation, a crucial practice in modern medicine. To appreciate the value of ventilation, we need to understand how the respiratory system works. We breathe by contracting our diaphragms, which expands our chest cavities. This allows air to be drawn in, inflating the alveoli, millions of small sacs inside our lungs. Each of these tiny balloons is surrounded by a mesh of blood-filled capillaries. This blood absorbs oxygen from the inflated alveoli and leaves behind carbon dioxide. When the diaphragm is relaxed, the CO2 is exhaled alongside a mix of oxygen and other gases. When our respiratory systems are working correctly, this process happens automatically. But the respiratory system can be interrupted by a variety of conditions. Sleep apnea stops diaphragm muscles from contracting. Asthma can lead to inflamed airways, which obstruct oxygen. And pneumonia, often triggered by bacterial or viral infections, attacks the alveoli themselves. Invading pathogens kill lung cells, triggering an immune response that can cause lethal inflammation and fluid buildup. All these situations render the lungs unable to function normally. But mechanical ventilators take over the process, getting oxygen into the body when the respiratory system cannot. These machines can bypass constricted airways and deliver highly oxygenated air to help damaged lungs diffuse more oxygen. There are two main ways ventilators can work: pumping air into the patient's lungs through positive pressure ventilation, or allowing air to be passively drawn in through negative pressure ventilation. In the late 19th century, ventilation techniques largely focused on negative pressure, which closely approximates natural breathing and provides an even distribution of air in the lungs. To achieve this, doctors created a tight seal around the patient's body, either by enclosing them in a wooden box or a specially sealed room. Air was then pumped out of the chamber, decreasing air pressure and allowing the patient's chest cavity to expand more easily. In 1928, doctors developed a portable metal device with pumps powered by an electric motor. This machine, known as the iron lung, became a fixture in hospitals through the mid-20th century. However, even the most compact negative pressure designs heavily restricted a patient's movement and obstructed access for caregivers. This led hospitals in the 1960s to shift towards positive pressure ventilation. For milder cases, this can be done non-invasively. Often, a face mask is fitted over the mouth and nose and filled with pressurized air, which moves into the patient's airway. But more severe circumstances require a device that takes over the entire breathing process. A tube is inserted into the patient's trachea to pump air directly into the lungs, with a series of valves and branching pipes forming a circuit for inhalation and exhalation. In most modern ventilators, an embedded computer system allows for monitoring the patient's breathing and adjusting the airflow. These machines aren't used as a standard treatment, but rather as a last resort. Enduring this influx of pressurized air requires heavy sedation, and repeated ventilation can cause long-term lung damage. But in extreme situations, ventilators can be the difference between life and death. And events like the COVID-19 pandemic have shown that they're even more essential than we thought. Because current models are bulky, expensive, and require extensive training to operate, most hospitals only have a few in supply. This may be enough under normal circumstances, but during emergencies, this limited cash is stretched thin. The world urgently needs more low-cost and portable ventilators, as well as a faster means of producing and distributing this life-saving technology.
So I hope you enjoy my video about the ventilator, the history of the ventilator. Thank you very much for listening, and God bless everyone.